Well, this is great because I can compare how we should report to some of the slides earlier, not trying to get personal, but we do have some recent information. This is really not controversial. While a lot of the things we've talked about so far this afternoon are controversial, this is not controversial. These are my disclosures. That's because there is now an expert consensus statement, the new version of it. The last version was out in 2012, and this is a consensus statement on catheter and surgical ablation that's been endorsed by every single major electrophysiology society and the major European and North American surgical societies. So we can all argue what you think is best. This is the present statement, and they clearly tell you how you should report results. And to be credible, we can't come up with our own idea of how to report whether or not we're successful. We have to follow these guidelines. And I would have to say, in my own opinion as an editor of our journal, that we really have to stop. I mean, I think Timo said it best. We have to generate evidence. We don't have evidence for hybrid ablation yet, but there are a number of groups trying to generate it. But we have to probably stop publishing a lot of small studies with very short follow-up. And I would have to say, looking at the literature, the majority of studies are not reporting the results appropriately, even by the 2012 guidelines. So we've had them. This isn't a brand new guideline. These guidelines in some version have been out. Really, this is the third version, which is for the last 15 years. So first, we've talked about a little bit. When you report your results, they do recommend for any ablation a blanking period of 3 months. And I think that we can follow whether we're doing surgical or catheter ablation. And that's the reason that there's a very high incidence of atrial arrhythmias following ablation, likely due to inflammation. And inflammation is very pro-arrhythmic and causes, as I tell the patients, it causes a different type of AFib. But with really significant inflammation, conduction velocity slows it. You can sustain a reentrant rotor in a less than half centimeter square piece of atrium. There's no way to prevent that. No way. And in fact, the most arrhythmogenic, I think, ablation is the Mays procedure, probably because we do so much ablation. But we've published an incidence of about 40% during the first month. So there is a blanking period, and I think we should honor the recommendation now for all of us is 3 months. And I think that's what we tend to follow. How do we define recurrence? Well, recurrence is really defined, again, and this is the third consensus statement that says, and whether or not any of us agree with it, that is how we have to report our results. And that is any arrhythmia, including atrial tachycardia and atrial flutter, not just atrial fibrillation. So it's not freedom from AFib, it's freedom from any atrial tachyarrhythmia that lasts greater than 30 seconds. And it doesn't matter how you monitor it. If they have more than 30-second duration of any of those arrhythmias, it's a failure. It's a failure by the guidelines, and we got to start following them. We talked about how to be credible in this field. To be credible is report them like every society has agreed we have to. And the primary endpoint of all studies and all clinical trials, I'll be happy to provide anybody these guidelines, is freedom from atrial tachyarrhythmias and drugs. You can't just present your freedom on drugs. Who knows what that means? That is what we need to see, whether it's a hybrid ablation, minimally invasive, left-sided ablation. It's freedom from all arrhythmias and antiarrhythmic drugs at 12 months. Forget about last follow-up. And we saw a slide, last follow-up. That's not good enough. I mean, what do we know by last follow-up? What does that even mean? I mean, was the follow-up, 1 month? Was it 5 months? And again, the primary endpoint, freedom from anything more than 30 seconds of any tachyarrhythmia at 12 months, and you're off drugs. Simple. They definitely recommend that other endpoints can be valid. I'd recommend reading it. It's interesting to me. Such as AFib burden. That has to be a secondary endpoint, not your primary endpoint of your paper. And success on and off antiarrhythmic drugs should be reported, but success on drugs is a secondary, not a primary endpoint. So they talk and they do say that the only way to define AFib burden is a continuous loop recorder. I really recommend they backed off from previous guidelines. They said this should be implanted preoperatively. If you're going to look at burden, you have to know what the burden was before the ablation. They felt that AFib burden and was not an appropriate endpoint for paroxysmal, only for persistent and long-standing persistent AFib. And AF burden, again, should only be used as a secondary endpoint, not a primary endpoint. How do they recommend following? And this has actually changed from the previous one to less aggressive following, which I thought was interesting. But again, this is the consensus statement. They're followed at 3, 6, and 12 months with a 12-lead ECG at each visit and a 24-hour Holter every 6 months. They do recommend a Holter and ECG every 6 months to continue on past the first year also. And they do recommend in this that if you have patients complaining of symptoms, that you should put an event recorder on after the 3-month blanking period. So again, whether or not we agree individually, these are the guidelines and the expert consensus statement. You can see it's quite a list. At WashU, what do? We follow people at 3, 6, and 12 months and then annually for life. We don't bring them back. They really don't want to come back every 6 months. And we get generally at each of those endpoints a 12-lead ECG and a 24-hour Holter. We do event recording in symptomatic patients as recommended. And we consider, and they recommend in the guidelines, if you have an intervention, whether catheter or surgical, after 3 months, unless it's a planned intervention like a hybrid procedure, then that becomes a permanent failure in your results. Now, is the minimum follow-up enough? Should we implant continuous monitors in everyone? I'll just show you some of our data. But in our experience, it has not been very practical to do that. We've had poor patient compliance, and we've met some resistance from insurers. And the poor patient compliance is not necessarily with loop recorders, but with the really prolonged, like 7-day Holters. And we published a prospective 2-institution study which showed that doing anything more didn't impact the results, our success rates after a maze. And we had a big problem with false positive rates. And this is the paper we published last year in Annals of Thoracic Surgery as a prospective trial with independent reading of the results. This was our compliance, and a compliance with a loop recorder. You think, how can that not be? But people don't want to necessarily download it. But you can see that our compliance, I think, is one of the highest reported. We had 96% compliance with the loop recorder at 6 months and 91% at 12. And so, we had very good compliance. We actually had pretty good compliance. The Holter is shown in the crosshatch. But this is our success, and basically as defined by the guidelines, our success really wasn't impacted much, mainly because we had pretty good success, and this is a relatively small study. I think you will pick up more AFib with a loop recorder. The question is that going to really impact your practice? And we have a big issue in the US with reimbursement, certainly after AFib ablation. These were these studies, though, when they did recur, you can see the AFib burden, and that's shown as a median, maximum, and minimum, was about 0.1%. So most of the patients, these are all had a full maze, so that the recurrence in these patients tends to be very minimal type of AFib. And I think it should remember whenever you look at the literature, when you're looking at these implantable loop recorders, their added benefit is going to be completely dependent on the efficacy of the ablation procedure you do. So if you do an operation that fails all the time, then no matter how you monitor the patient, they're always in AFib. If you do a patient that succeeds all the time, then the duration of monitoring will also have little impact. So I would have to say one of the reasons I think our study doesn't show much is our success rates are pretty high, certainly at 6 and 12 months. They get worse as time goes on. I just would quickly show the time it takes, and we follow, so people can download these, and we were having them download them bi-monthly, and you get up to 16 episodes to review, and these are 2-minute episodes of recorded electrocardiograms. So you can imagine if you're following 100 patients, that's 1,600 episodes you'd have to review, and these are 2-minute strips for monthly downloads from a reveal, 3,200 episodes for bi-monthly episodes. I follow personally 400 patients we see every year, and imagine if I had 400 people with a reveal, that would be 12,800 episodes for bi-monthly downloads and 6,400 episodes for monthly. And to review that, even if I only spent the 2 minutes per rhythm strip, and they last for 2 minutes, so that would be, I'd have to be very efficient to do that. It would take me about 6 hours a day to review that. I mean, it's really impractical. And there's a huge medical legal issue. So unless you have a really dedicated nurse who can do it, I would absolutely suggest not to put that in, or if your EPs are going to do it. And certainly this was the first generation Reveal. The next generation is better. But we did review all the electrograms we had available, which is actually a very small percentage of the episodes. And it's just important to remember that with the Reveal, the false positive rate, 59%. So when you had an electrophysiologist look at it, it was calling AFib 60% wrong. So if you don't review it, you've got a real problem. You actually have got a little bit of a problem either way, because if the patient has a stroke, you know, you're going to have someone probably come back to you and say you were over-aggressive or not. So, and it's just the fact in this prospective trial, only about 10% of the episodes, because the monitor overwrites itself. It records anything it thinks is AFib, but by the time and this was with the bi-monthly download, only about 10% of the actual episodes were there. So I won't really go this. The final thing, you can't report your freedom as a Kaplan-Meier curve, I would have to say, and that is in this guidelines, but I really have strongly felt that that's not appropriate, because that would mean that if you fail at any point, you're a failure forever. It's not like dying. Atrial reverse remodeling, particularly in concomitant patients, continues over time. And also there are many different etiologies for AFib, particularly sepsis, infection, thyroid derangements that are episodic. So it's really recommended to report your freedom from atrial arrhythmias and drugs at endpoints, defined endpoints, and we mentioned the primary endpoint is 12 months. But you really have to define it at those time periods and not at last follow-up. And I think we all need to do it better. However you determine your recurrence rate, the type of follow-up monitoring clearly should be specified and can have an impact. Clearly, the most sensitive way is with a loop recorder that would be then evaluated by trained personnel, either a nurse practitioner, surgeon, or electrophysiologist. This is just our paper, just an example of how we report our results. This is just looking at freedom. I think I showed this slide before. Freedom, this is freedom from all antiarrhythmic drugs. I will have to say, for disclosure, slightly at 5 years, about 54% of the patients had prolonged monitoring of 24 hours or more. The rest were ECG monitoring. But you can see off drugs at 78%, but if you look at on drugs, it falls down to 66%. Didn't depend whether you were on or off drugs. But again, as I said, it's very rare. This is all Maze 4 data, but it's rare. But I mean, we have to start reporting our results like this and pretty rigorously to be credible, and I wouldn't think we are. I would just make a plug. We are going to do, this is a complex topic with a lot of different viewpoints, which you've seen. We are doing a 2-day course in Miami in November, sponsored both by ATS and Heart Rhythm Society, which I hopefully will be able to clarify this and invite any of you to come. Thank you.